Let's move on to the second part of the lecture, which is the pharmacotherapeutic management of kidney diseases. In this part, we will focus on the chronic kidney disease. Based on the United States Renal Data System annual data report in 2018, reported that Malaysia is the second fastest rising kidney failures globally. The prevalence of chronic kidney disease in Malaysia was 9.1% in 2011 and up to 15.5% in 2018. Based on the Malaysian Dialysis and Transplant Registry reported that 7,967 new patients received dialysis in 2015. And by the end of 2016, there were 39,711 patients on dialysis. If the present trend continues unchecked, the number of end-stage kidney disease patients is estimated to reach 106,000 in 2040. This burden will cost the healthcare system, as reported that the total annual expenditure of end-stage renal disease by the public sector has grown double within a span of 7 years, which from 572 million in 2010 and up to 1.12 billion in 2016. This is the case study that we will use to discuss in this week's lecture. Madam SS, 42-year-old Afro-Caribbean woman, presents to her general practitioner with 6-week history of headache and lethargy. During examination, the following is noted. In her dipstick study, she is positive on the proteinuria. Her blood pressure was 180/105 mm². Her serum creatinine level was 365 micromole per liter and the serum urea was 15.8 millimole per liter. Her albumin creatinine ratio or ACR is 15 mg per millimole. Her weight was 98 kg and height 180 cm. Madam SS was prescribed with nifedipine 30 mg once daily and enalapril 10 mg twice daily to treat his hypertension. After 1 week of the treatment, his BP was still only 150/85 mm², but the patient was complaining of very swollen ankles. He also mentioned that he has developed a persistent cough. These are all the risk factors in developing chronic kidney disease leading to end-stage renal failures, which are diabetic patients, hypertensive patients, patient who has heart problems or stroke, obesity patient, or any of his family members developing chronic kidney disease, smokers, and aged more than 65 years old. The first step, we need to evaluate her renal profile by calculating the estimated glomerular filtration rate, either using 2009 CKD EPI creatinine equation or Cockcroft-Gault creatinine equation. In the latest guideline, they prefer to use the 2009 CKD EPI creatinine equation. In this formula, we need to know the serum creatinine level in milligram per deciliter. Besides, we also need to know the patient's age and gender. Since Madam SS is a female, her K value should be 0.7, while the alpha value will be negative 0.329. For Cockcroft-Gault creatinine clearance method, the serum creatinine level should be in micromole per liter. Before that, we need to calculate the BMI of the patients to know whether she is more than 25 or not. If she is overweight or BMI more than 25, we need to calculate the ideal body weight for these patients by using this formula. Adjusted body weight will be used if the patient's actual body weight more than 1.3 times from ideal body weight. Let's see how to use this formula. For 2009 CKD EPI creatinine equation, first of all, we need to calculate the serum creatinine divided by the K constant value. From the case study, we can see that the Madam SS serum creatinine value in the milligram per dl was 3.45 divided by 0.7. The answer should be 4.93. This 4.93 will be put in the equations to choose the minimum value and maximum value compared to the 1. That's why for 2009 CKD EPI creatinine equations, we use that 141 times with 1 power of negative 0.329 times 4.93 power of negative 1.209 times 0.993 power of 42 times with the constant value, which she is female, times with 1.018 and she is black, so times with 1.159. So the answer should be 18 milliliter per minute. So this is her EGFR using the 2009 CKD EPI creatinine equation. Using the Cockcroft-Gault creatinine clearance method, you need to use the serum creatinine in micromole per liter. Before that, you need to calculate the body weight, ideal body weight, and adjusted body weight if the actual body weight more than 1.3 than ideal body weight. So her BMI was 30.25, which reflects that she is an obese patient. And for ideal body weight, we can calculate that her ideal body weight should be 70.8 kg. Comparing the actual body weight with ideal body weight by times the ideal body weight with 1.3, you can see that the actual body weight 98 kg is more than 1.3 ideal body weight. So that we need to use the adjusted body weight as shown here. It's calculated that adjusted body weight was 81.68 kg. So this adjusted body weight will be used in the Cockcroft-Gault creatinine clearance equation. Put it in the value in the formula, you can calculate that creatinine clearance for this patient using the Cockcroft-Gault creatinine clearance was 22.81 ml per minute. After you calculate the estimated glomerular filtration rate, you need to classify this patient with using the kidney disease improving global outcome staging. There are 5 stages for this chronic kidney disease. Before that, the prognosis of chronic kidney disease is based upon 4 factors, which the first one, the cause of chronic kidney disease, as mentioned previously, the GFR category, albuminuria category, and other risk factor and comorbid conditions. The 5 stages depend on the calculated GFR value. Stage 1, Stage 2, Stage 3, Stage 4, and Stage 5. Stage 1 reflects that her kidney is a normal or high function, which the GFR value should be more than 90 ml per minute. If the GFR value between the 60 to 89, we can classify the patient to this stage 2, and so on. If her GFR less than 15 ml per minute, she can be considered as stage 5 or kidney failure. So she required dialysis for continuing her life. Classification of CKD can be categorized based upon GFR category and albuminuria category. As mentioned previously slide, GFR category can be classified into 5 stages, which are G1, G2, G3, G4, and G5 depends on the calculated estimated GFR value. Meanwhile, for the albuminuria category, we can use either albumin excretion rate or albumin creatinine ratio to categorize them as A1, A2, or A3. To identify the prognosis of chronic kidney disease, we need to compare her GFR value and the albuminuria categories. The green zone refer to low risk to get the chronic kidney disease. Meanwhile, the yellow box refer to moderate risk to getting the chronic kidney disease, while orange color and red or deep red refer to the high risk and very high risk respectively. Based on the calculation just now that we have calculated and also the ACR value, we can categorize Madam SS is a stage 4 chronic kidney disease due to its glomerular filtration rates in the range of 15 to 29 ml per minute. Based on the table given here, she is a very high risk in developing end-stage renal failure due to categorized as G4 based on GFR category and A2 based on albuminuria category due to ACR value in between 3 to 30 mg per millimole. We need to suggest her to monitor her blood glucose and blood pressure regularly to reduce any predisposing factors that can worsen her kidney function. So as a pharmacist, what is our role in delaying the progression of chronic kidney disease? After we identify the risk of the patients, we need to start or initiate appropriate intervention as early as possible. Thereby, we can slow or halting the progression of chronic kidney disease to end-stage renal failure. Here is our aim. First, we need to delay its progression. Second, we need to reduce any cardiovascular risk that can worsen the kidney function. And the third, we need to manage the chronic kidney disease related complications. Here are our strategies. First of all, we need to optimize the blood pressure. Besides that, we need to control her blood glucose. The use of renin-angiotensin system blockers such as ACE inhibitor and angiotensin receptor blocker or ARB is useful, especially for the proteinuria chronic kidney disease. We need to advise the patients to change her lifestyle, especially to stop from smoking, reduce her weight, and control her diet, which must low salt diet and low protein intake. And as well, we need to avoid any potentially nephrotoxic agent that can worsen her kidney function. Our first strategy to protect the kidney, or we call it as a renoprotection, is target for hypertension and proteinuria patients. Proteinuria is a protein that can be found in the urine. It's an independent predictor for renal disease progression. The degree of proteinuria reduction correlates with the degree of delaying the chronic kidney disease progress as well as the cardiovascular disorder mortality reduction. Any class of antihypertensive agents can be used to control the blood pressure in CKD, but please bear in mind that only few have additional anti-proteinuria effect that we can discuss later. Lowering the blood pressure has huge impact on the all-cause mortality, cardiovascular event, reduce the stroke risk and progression of kidney disease. In general, blood pressure target for CKD patients should be tailored based on diabetes status, level of proteinuria, and cardiovascular risk profile. The blood pressure target should be individualized according to comorbidities and age. In general, for hypertensive patients, the blood pressure target should be less than 140 over 90 mm mercury, which we need to emphasize that the systolic blood pressure within the range 120 to 140 mm mercury. In contrast to the chronic kidney disease patient or CKD patients, the blood pressure target should be tight, which is 130 over 80 mm per mercury. So for Madam SS, her BP target should be less than 130 for systolic and less than 80 for diastolic. Here is the algorithm to review her medication to treat the chronic kidney disease. Once the patient been diagnosed as a chronic kidney disease patient, we need to identify them whether they are diabetic or non-diabetic patient. For the non-diabetic patient which uncontrolled her hypertension and didn't present any protein in the urine, any class of antihypertensive agent can be used to treat the hypertension. However, the choice of class will depend on the patient's comorbidity. ACE inhibitor or ARB, angiotensin receptor blocker, should be used as first-line agent in diabetic kidney disease with albuminuria or non-diabetic kidney disease with the presence of proteinuria more than 0.5 gram per day. ACE inhibitor and ARB cover both renoprotective and cardioprotective effects. Many clinical trials has proved that this agent significantly reduce the progression from microalbuminuria to macroalbuminuria and as well as induce the regression from the microalbuminuria to normal level. However, please bear in mind that there were no benefit of ACE inhibitor use and ARB use for non-diabetic kidney disease if proteinuria less than 0.5 gram per day. We need to monitor the renal profile of the patient following the initiation or dose escalation of ACE inhibitor or ARB. The dose of ACE inhibitor and ARB should be titrated up to the maximum recommended dose to achieve the optimal blood pressure and has the antiproteinuric targets. Renal profile should be reassessed within 2 weeks upon initiation or dose escalation of ACE inhibitor or ARB therapy. We need to reduce or discontinue of ACE inhibitor or ARB after we excluding any other precipitating factors when the serum creatinine levels remain more than 30% from the baseline or the eGFR reduced more than 25% or the serum potassium is more than 5.6 millimole per liter, or we call it as a hyperkalemia patient. Do combination of ACE inhibitor and RRB is getting benefit to the patient? The dual therapy has this synergistic effect, which the additional reduction in proteinuria and decrease the hospitalization for heart failure in both diabetic and non-diabetic patients. However, it does not reduce the mortality and has higher risk of adverse effects such as hyperkalemia, hypotension, and acute kidney injury compared with monotherapy. Hence, this dual RAS blockade should not be prescribed routinely. It may be considered if the patient has non-diabetic kidney disease patient who remain hypertensive and persistent proteinuria more than 0.5 gram per day and the serum potassium is within the normal range. In clinical practice, calcium channel blocker act as an add-on therapy to RAS blocker in the management of chronic kidney disease. RAS blocker and CCB. Combination of RAS blocker and CCB is a reasonable and safe approach to optimize the blood pressure control. However, only the non-dihydropyridine CCB such as verapamil and diltiazem and certain subtype of dihydropyridine CCB such as lecanidipine, azanidipine, benidipine and clinidipine have the additional anti-proteinuric effect. The combination of RAS blocker and aldosterone antagonist able to reduce the proteinuria and reduce the blood pressure level. However, for the non-selective aldosterone antagonists such as spironolactone offer many adverse effects such as hyperkalemia and or gynecomastia. That's why we more prefer to use these selective aldosterone antagonists such as eplerenone and finerenone, which these two drugs has less or fewer adverse effects. The effect of finerenone in the urine albumin-creatinine ratio depends on the dose itself. Let's discuss back our case study. As mentioned before, Madam SS prescribed with nifedipine 30 mg OD. So this nifedipine is a calcium channel blocker, which is dihydropyridine calcium channel blocker, which has been thought that this nifedipine CCB didn't have any anti-proteinuric effect. Besides the nifedipine, the Madam SS also received enalapril 10 mg BD to treat her hypertension. So this enalapril 10 mg BD is an ACE inhibitor. After 1 week of the treatment, her blood pressure still 150 over 85 mm mercury, but the patient was complaining of very swollen ankles. He also mentioned that she has developed a persistent cough. From the previous discussion, we already classified the Madam SS as a stage 4 chronic kidney disease due to her GFR value within the range of 15 to 29. Thus, the swollen ankles due to the severely decreased renal function, which the kidney unable to excrete excess fluid that cause accumulation of fluid at her ankle. So that we suggest to change her medication to the diuretics. Besides that, the persistent cough is due to the side effect of ACE inhibitor. So the patient is intolerant to the ACE inhibitor, and we want to suggest to change to the ARB. So as a conclusion, the best medication for her to delay the progression of chronic kidney disease as well as to monitor the blood pressure in the normal range, we would suggest to use the angiotensin receptor blocker or ARB combined with the selective antagonist aldosterone diuretic, which is eplerenone. Besides controlling her blood pressure level and reducing the protein excretion through urine, we also need to monitor the glucose level, which the glycemic control able to protect the kidney. The target for the HbA1c should be between 6.5% to 7%, which this range of value able to reduce the development of micro and macroalbuminuria. However, aggressive glycemic control in patients with established CVD increase the risk of hypoglycemia and death due to impaired drug metabolism. The best antidiabetic that can be used to treat the glycemic control is the sodium glucose cotransporter 2 or SGLT2 inhibitors, which has been proven to reduce the cardiovascular outcome and have the renoprotective effect. The empagliflozin has reduced the incidence of worsening the nephropathy by 39%, and the canagliflozin able to reduce the progression of albuminuria. Here is the list of dosage recommendation in chronic kidney disease for oral antidiabetic agents. Let's see here. If the patient on metformin, the usual dose should be 500 to 1000 mg twice daily. However, if her kidney profile deteriorates, which in the level of 30 to 59 ml per minute, she needs to reduce her dosage to 30 to 50%, or avoid if the glomerular filtration rate less than 30 ml per minute. Even though sodium glucose co-transporter 2 or SGLT2 inhibitor has the renal protective effect, it didn't mean that this drug can treat the kidney function. This SGLT2 inhibitor should be avoided if the kidney function less than 30 ml per minute. And we need to adjust the dose when the eGFR value within the range of 30 to 59 ml per minute. Besides adjusting the oral antidiabetic dose, we also need to review all prescribed medication in the CKD patients, such as lipid lowering agent as stated here. Here is the list of the antihypertensive drug that we should adjust the dose according to the eGFR that we calculated. The only antihypertensive drugs that affected is the diuretics drugs. Try to avoid using the thiazide diuretics and potassium sparing diuretic when the GFR value less than 30 ml per minute. The loop diuretics, bumetanide, furosemide, as well as the aldosterone antagonist is safe to be used. We should encourage and counsel CKD patients to having the low protein diet. Protein restriction is one of the supportive measures to delay the CKD progression. For the diabetic kidney disease, the protein intake should be in the 0.8 gram per kilogram per day. For the non-diabetic kidney disease, we will recommend them to consume 0.6 up to 0.8 gram per kilogram per day. And for the pre-dialysis CKD patient, which is in the non-DKD stage 4 and 5, we will recommend to restrict her protein diet up to 0.3 gram per kilogram per day with keto acid supplementation. The two most common complications for CKD is anemia and chronic kidney disease mineral and bone disorder, or also known as CKD-MBD. Anemia is defined as a hemoglobin concentration of less than 30 gram per dl for adult males or less than 12 gram per dl for adult females. This is because reduce the erythropoietin production by the kidney and reduce the absorption of iron. The optimal hemoglobin target in CKD patient is 10 to 12 gram per dl, so that the iron supplementation is necessary to replace the iron stores, and we prefer intraventricular compared to oral drug. Treatment with ESA or erythropoiesis stimulating agent should be commenced by the nephrologist. When the patient has glomerular filtration rate less than 60 ml per minute, they will cause changes in the metabolism of calcium, phosphate, parathyroid hormone, and alkaline phosphatase or ALP. As kidney disease progresses, the renal activation of vitamin D is impaired, which reduces the gut absorption of calcium. The low blood calcium concentration stimulates the secretion of parathyroid hormone. As the renal function declines, the serum calcium balance can be maintained only at the expense of increased bone resorption, resulting renal osteodystrophy. Calcium level that less than 9.5 mg per dl and phosphorus level less than 4.6 mg per dl must be controlled before initiate the vitamin D therapy. For the hyperphosphatemia patients, we need to restrict the dietary intake of phosphate which within the 800 to 1 gram per day, prior considering the use of phosphate binders such as calcium carbonate, magnesium hydroxide, aluminum carbonate, and aluminum hydroxide. To treat the hypercalcemia patient, we need to avoid excess calcium administration and vitamin D analog, which these two supplements lead to increase the risk of vascular calcification in chronic kidney disease.